There we go. Thank you so much, Dave. In the 1980s, a preventive medicine doctor named Vincent Felitti was running a morbid obesity clinic at Kaiser San Diego. And his patients were not getting better. One of his patients had the insight that although she wanted very much to lose weight, ever since she had been sexually abused as a child, being overweight protected her from more abuse. It made her invisible. In 1999, Dr. Felitti, along with Dr. Robert Anda from the CDC, published what would become the landmark ACEs study, showing that adversity in childhood is a major contributor to not only obesity and self-harming behavior, depression, anxiety, but also chronic disease and early death. My name is Deirdre Bernard Pearl, and I am the Pediatric Medical Director at Santa Rosa Community Health. I decided to make my CHIP about incorporating ACEs screening into primary care. I'm going to ask for control of the slides. I'll keep going, but I can't advance my slides. I have been keenly interested in ACEs for a number of years. As I started doing discovery interviews around my health center, I was plagued with a nagging question: how might we do ACEs screening throughout Santa Rosa Community Health? And this became the problem that I sought to address with my CHIP. I discovered a key strategy would be becoming trauma-informed, understanding challenging patient behavior by asking not what's wrong with you, but rather what happened to you. So what exactly are adverse childhood experiences, or ACEs? There are 10 types of ACEs that fall into 3 categories. The 3 categories are abuse, neglect, and household dysfunction, which means growing up in a household where a parent was mentally ill or substance dependent, incarcerated, where there was parental separation or divorce or domestic violence. A person's ACEs score is defined as how many of these 10 types of ACEs a person experienced in childhood. Felitti and Anda found that adverse childhood experiences are not only highly prevalent, but consequential. I think I'll pause for a moment and ask for a little technical support. I'm not able to, oh, there I go. Okay, thank you, whatever you've done. Okay, 3 categories, here we are. ACEs increase the risk for 9 of the 10 leading causes of death in the United States. A person with 4 or more ACEs has twice the chances of heart disease, cancer, and stroke, 11 times the odds of developing Alzheimer's disease, and 37 times the chance of a suicide attempt. When I learned about these findings a long time ago, I realized that ACEs are a crucial part of health history. And 6 years ago, I started asking my patients questions about their ACEs at the pediatric clinic. So my actual CHIP project was for me to seek out existing ACEs resources, apply for funding support, and bring training and resources into all of the family medicine clinics of Santa Rosa Community Health. My goal was to have this done and train 100 people by June of 2020 in this program, so that screening for ACEs was occurring in 50% of primary care visits by summer 2020. Here's the questionnaire that I originally started using at my pediatric clinic. I know this is too small to read, but I wanted to give you an idea of the written format of the questionnaire. Before I started asking the ACEs questions, I really thought that I knew my patients very well. I took a lot of time getting to know them. But once I started asking these questions, I found out so much more about them. And this helped them understand some of their health struggles in a new way. And many of them have been able to open to getting help. I also found that it increased trust. And then, as I was developing my CHIP, I learned about 2 statewide initiatives trying to accomplish the exact same thing. And because I had already started sharing my early ACEs work, I was asked to join both initiatives to advise about design and implementation. The first was ACEs Aware, a program created by California's first Surgeon General, Dr. Nadine Burke-Harris. The second was CalQuick, which stands for the California ACEs Learning and Quality Improvement Collaborative. Working on these statewide initiatives has helped me formulate my CHIP strategy. I also applied for grants to support my CHIP and was able to get $200,000 for my organization to do this work. I'd like to share just a little bit more about each of these programs. ACEs Aware focuses on these 3 areas. 1, screening patients for ACEs. 2, treating ACEs with evidence-based approaches like trauma-focused cognitive behavioral therapy. And 3, healing ACEs. Often what patients need is not treatment per se, but resources and support. At my organization since January of 2020, over 100 employees have been trained. And this includes physicians, advanced practice clinicians, nurses, psychologists, and social workers. I also created a version of the training for the staff, including medical assistants and receptionists, and have already trained over 50 staff members. The second statewide initiative is the California ACEs Learning and Quality Improvement Collaborative, which is a partnership between UCSF Center to Advance Trauma-Informed Care and the Center for Care Innovations. This program provides funding resources to support a statewide learning community, coaching for the teams, and access to technical experts. Santa Rosa Community Health is one of the 15 sites across California participating in the CalQuick Collaborative. I built this multidisciplinary ACEs work group at my organization to include a wide range of leaders in medicine and mental health, as well as folks from the quality department, EHR team, and very importantly, frontline staff. And we all agree that ACEs screening is really not at all like other questionnaires. We cannot just start asking these deeply personal questions in primary care until we train all of the staff on why we are doing this and make sure supports are in place for patients and for preventing and mitigating secondary traumatic stress in the staff. It's truly a culture change. We see this work as being all about becoming what's called trauma-informed, starting with a deep understanding of trauma and toxic stress physiology. It is grounded in cultural humility and equity and emphasizes resilience and recovery. We wanted to let our patients know that we would be asking them about trauma, and so as a team, we created this poster for the waiting room and exam rooms. The goal was to normalize screening, to be gender inclusive, family-centric, and to use healing imagery. The feedback has been positive so far. Patients rarely refuse the ACEs screening, and they often thank us for asking. And then, just 1 year ago, as my CHIP was getting going, this happened in Santa Rosa. The Kincaid fires disrupted everything, and for the 3rd consecutive year, wildfires had devastated Sonoma County, and I knew I had to do something about it. I turned to my podmate, Pana Lassi, and I asked if I could join her work, developing a scalable approach to providing medical care in evacuation shelters. And then it was shortly after our CHCF seminar in Sacramento that COVID happened, and I'm going to turn it over to Pana here at this point. Pana, we're not hearing you.
Mm-hmm. Sorry about that. Got to unmute. So thank you very much. Like Deirdre, as Deirdre said, I had a project prior to COVID, which was setting up a virtual toolbox to help people in evacuation centers set up medical care. And in the interest of time, I'm not going to talk about that at all. But if you want to know more, you can go online to the disastercrashcart.org. So go ahead to the next slide, Deirdre. So in March of 2020, COVID hit, and this is a picture of me in full PPE doing the testing in our new drive-through COVID clinic. So imagine the line of cars, and in one of those cars, Maria, a 72-year-old Latina with uncontrolled diabetes, was there to get tested because of her cough. She had her daughter and her granddaughter in the car, and as we talked, they mentioned that the little girl's father had cancer and was on chemo. So not knowing what else to do, I continued on to collect the swab and handed them a handout telling them they needed to isolate, and with some information about how to do that. And they said, oh, don't worry, Doc, we got this. We're gonna stop by Costco and pick some stuff up and we'll be home and we're good. I really didn't know what to say. What we are asking of people is almost impossible. And the health centers really don't have time to do robust education or resources to offer. And I just need to say that this is a social justice issue. It is outrageous that once again we rely on the most vulnerable, the low-income essential workers, to make the sacrifices needed to stop this pandemic. How are they supposed to actually stay home or even protect their families if we don't educate them on how to do that and provide supplies or food? Support makes it possible to home isolate and builds trust, which helps them to continue to do that. Early education is key to containment of the virus. We're missing the infectious period if we wait until a test comes back positive before we start educating people about how to isolate. And that means the disease spreads in the household, especially in small, crowded households. I'm sorry, Deirdre, can you advance the slide 2 more? Yeah, and go one again, please. So I reached out to friends and one of whom was Deirdre, and also many other people, to figure out how we could, I'm sorry, back 1 slide. How we could do something to make a difference here. And so we set up IsoCare, and we trained over 150 volunteer community health workers to make phone calls to be able to educate people on how to prevent the spread of COVID and individual situations, as well as give them emotional support and links to things like masks and all of that. So next slide, please. We set up a phone bank in order to make people be able to have calls at the same time to many different people making calls. And we developed phone banks in both English and Spanish to reach our patients. Next slide, please. So in the last 6 months, we've supported over 2,000 people. And until last month, this was 100% volunteer effort. So with this phone bank tool, we're able to collect data. And as you can see, we've had good success at reaching people to go through our complete intake, which takes about 20 to 40 minutes. Next slide. Some of the information we can gather is interesting just in terms of how many people have their own bathroom, and which is one of the key things for successful isolation. And as you can see, that is not very common. Next slide. And this is interesting data about how slightly more English speakers are reporting that they have a household member who leaves the house. Next slide. But more of the Spanish speakers are going to work. Next slide. So the IsoCare is growing. We recently got a grant from our county to support this work. And we have a grant from Kaiser to help spread the model and provide support to public health in innovative ways, like helping to prioritize case investigation or starting contact tracing before test results are back. We are actively looking for new partners that are interested in starting something similar. But I just have to bring us back to the personal. Last month, as the fires once again raged in my county, we had a shortage of volunteers to make calls. So I found myself sitting in my car on the side of Bodega Bay making calls. And as I got off the phone with Sylvia, who had been exposed by the aid of her autistic son, I thanked her for all of the sacrifices she was making to protect the larger community. She said the exact same words that the client previously had said. Tenemos que cuidarnos uno al otro, which means we have to take care of each other, but more literally translated, we have to take care of us, one to the other. For me, this CHIP journey has been all about working together. Next slide. So this is me and Deirdre, Thelma and Louise going through this project, and I'm turning it back to her to take us home.
Thank you so much, Louise. Panna. I'm going to jump us back to the most recent disaster to hit us, September 9th, 2 weeks ago. The sun never came up. This is 9 o'clock that morning at my clinic. That eerie feeling we shared of that dark red sky was yet another trauma we all experienced together. Our world had changed. We had the pandemic, the wildfires, and now indisputable, palpable evidence of climate disruption. All of these things happened to us, not because we caused them, but just like our patients' childhood traumas, they happen to us. They deeply affect us. And there is urgent work to do to mitigate their harmful effects, to work to prevent them in the next generation. I'm looking forward to getting back to completing the ACEs trainings and the screening rollout in the near future. We've switched over to the ACEs form developed by the Surgeon General's office called coincidentally the PEARLS, and I'm working on a way to screen parents during the pediatric visit as well. There are already support groups for medical providers at some of the sites in Santa Rosa, and I'm piloting a similar support group for staff members who are deeply affected by this work as well. I'm also planning to pilot a follow-up visit for patients who score 4 or above to do further assessment, which might include a patient symptom inventory and other tools. If you would like to learn more about healing ACEs and trauma-informed care, you might consider attending a one-day Zoom conference on October 10th, where I'll be presenting more of this work. Thank you so much to the California Healthcare Foundation for creating this transformational program. Special thanks to my pod, and especially Panna Lassi. Through my CHIP, I've learned so much about trauma, adjusting priorities, and most of all, the power of collaboration. Thank you so much.
Thank you. I don't see any questions in the chat. Do we have 1 or 2 questions that people would like to unmute for and ask aloud? We have about 5 minutes for questions.
Deirdre, Panna, can you let us know the website and how to donate to your projects? I love this because it's
sure.
One of the first
Disaster Crash.
Yeah, go ahead.
Disastercrashcart.org is the website for the information around how to set up an evacuation center. And isocarenetwork.org is the website for IsoCare. And I don't know, Deirdre, do you have an answer?
Do I have an answer about how to donate?
How to donate to your project.
Oh, no, I think this is about donating to ISOCare. It's on the ISOCare homepage.
Last call for questions if anyone wants to unmute and ask a question. Otherwise,
This is Mike.
This is Sunita. So congratulations, that was amazing. I have a question for you. We don't often see paired projects where two people have come together to do it. What made it possible for you to do it? What did it take? Either of you.
Well, I'll take a stab at that. I mean, for one, it took the relationship that we had built, of course, over the first year. My pod really got pretty close. We got to know each other really well. We had been through some very serious family losses during this fellowship, and we'd spent a lot of time together. So we, I think that was the first main thing. And then when I started asking Pana about helping out with her project, I reached out to Dave and said, is this okay? You know, I mean, I'm really excited about my work, but Dave, you know, gave us the thumbs up that he saw that there could be real value in doing a combined chip, that we could really work together and achieve something bigger.
I would also say that we have very complementary personalities. Deirdre's, you know, much more introverted than me and much more sort of inclined towards analysis. And so that helps a lot too. I'm the kind of get it done gal.
thank you both. So I see we have two other questions. Michael Changaris, I'll take it from you, and then Ann Lindsay will be next.
These seem like incredibly impactful projects and have a wide-ranging impact. And one of the things I'm sitting with is using them as a model for other areas. How did you build the collaboration necessary to get them off the ground? It seems like there's a lot of stakeholders that might have come in.
Honestly, for ISOCare, I would say, you know, there's so much generosity of spirit when it comes to responding to disasters that asking for help is what led to the collaboration that made that possible.
Thank you. Ann.
Yeah, thank you very much. Great project. But I'm wondering who does the ACE screening in the clinics? Is it the medical provider or an RN or a medical assistant? And how does it fit in a 15 to 20-minute visit slot?
Oh, thank you so much, Ann, for that really perfect question. There are different approaches in different centers. And in this collaborative, I'm learning about other clinics that do it different ways. I can tell you how we do it and how we found it to work well. The medical assistants do the screening in the sense that when they room the patient, it's done on paper. We'd like to make it paperless, you know, that's the dream at some point, but they introduce it and the reason why it's being given, and the patient fills it out with paper and pen, and then the medical assistant enters it into the EHR. We found there's research now. I mean, we found that it really takes less time in the primary care visit than most people would predict. And the literature is showing that it generally, and there of course are exceptions, but generally it does not add any more than 5 minutes to a primary care visit.
Fantastic. I know there are many more questions out there and we could dive into these projects. The collaboration between Deirdre and Pana has been tremendous, and I'm delighted to see this model of collaboration between the fellows. I think it's great, and I hope to do more going forward. So congratulations to you both, and I'm delighted that I have two projects that can that have websites that I can point people to and say, yes, go put money in there because it's very valuable. Thank you both, and congratulations. Our next presenter, oh, where did my list go? I know exactly who it is. It's Tracy Peck Holcomb. And I don't have her title because it's buried under one of my other windows on my computer. This is what happens when you don't have paper printed out anymore and you go fully digital. But I've enjoyed my time with Tracy over the past 2 years, and I think you're going to look forward to hearing about this project. So let me turn it over to her.
She's the Director of Clinical Services, Hearing and Speech Center of Northern California.
Thank you, Melissa.
Thank you, guys. Give me 1 second, I'll pull this up.
Tracy, we see a note that your bandwidth is low, so that's why it might just be taking a minute longer. Here we go.
Okay, can you all hear me okay? I got a thing just flashed across my screen saying unstable internet connection, so that's never a positive start to a presentation, but we'll give it a go here. Thank you everybody for being here today. I want to start out by saying that I truly feel that my chip chose me. I didn't choose my chip. I remember that first seminar in Tiburon, and everybody's excited. We're talking about our different ideas. I had several in mind, including this particular project, but I hadn't decided yet on which direction I wanted to go. Oh, I can't advance my slide. It's okay, I'll just keep going. So about a month after that seminar, I was coming home from work one day, and there was a homeless individual on my doorstep. He was kind of fumbling around with something, and I couldn't quite tell what it was. So I got out of the car, asked if I could help him, and he proceeded to tell me that it was a flashlight. He was trying to fix his flashlight because he had significant hearing loss, and at night his eyes are his ears. With the flashlight, he can't see what's maybe coming towards him, from behind him. For safety reasons, since he can't hear, he really, really needed to be able to see. So I went inside, came back out with it, gave him a flashlight. We kept talking, and I mentioned that I had just come from this amazing seminar. I was going to start this program and this partnership to be able to address exactly his needs. I gave him my card. Turns out we had a mutual contact through Project Homeless Connect, and I said, I will absolutely be in touch. I don't know. Sorry, guys, I'm trying to, it won't let me advance.
Try the scrolling down on your mouse.
There you go. Did it cheat? Yeah, okay, I'm sorry.
Yes, we'll just make sure everybody else is on mute. That would be great. Thank you.
So the problem, hearing loss is very common. 1 in 3 people over the age of 60 has hearing loss, and that number jumps to 2 out of 3 at the age of 75. It is the 3rd most prevalent chronic healthcare condition in Americans, second after arthritis and hypertension, and it is the #1 service-connected disability for veterans. And additionally, it is linked to many other healthcare conditions, including depression, anxiety, increased risks of falling, but notably accelerated risk for cognitive decline and dementia. In fact, treating hearing loss is the top modifiable risk factor for dementia, exceeding others such as smoking, high blood pressure, lack of physical exercise, and social isolation. So essentially, addressing hearing loss is very likely to mitigate other health-related issues and improve overall health and well-being. And as a result of that, also likely to reduce overall healthcare costs. It is a critical component of holistic care. if you couple that with the fact that we've been aging homeless population, a study in 1990 showed that national
I think we just lost Tracy. It looks like her presentation went away and she may have dropped. So Gina, what I'd recommend at this point is if Winnie's ready to go, what we do is we shift over to Winnie and then we pick up Tracy again later, or we can wait. Either one. What do you think, Renee? Or
I think Tracy's on. I think she's in the. I see her video, but she's muted.
On my end, it looks like she's completely gone. So let's see, I think, and Dave, you don't see her as either. I think we should move.
I see her.
You do? Oh.
Yeah, I do too.
Yeah, she's on.
She's there.
oh, there she is. Yep,
here.
You're on mute, Tracy, but we can see you.
Oh,
I can hear you now.
If everyone in Tahoe turns off their video, that might help.
Okay, I'm sorry, everyone. Sorry.
As an option too, the speakers can send their slides to me and I can display for those who need.
I can send them out on Slack or send them to you afterwards too if people want to review them themselves. Where was I? So a study in 1990 showed that homeless adults older than 50 was at 11%, and in 2019 it had jumped to 50%. And additionally, the most, I think, remarkable stat is that 44% of those individuals first became homeless after the age of 50. The researchers also found that older homeless individuals have far more significant and serious issues with things like depression, vision, hearing and balance than housed people of the same age. So homeless people in their 50s generally display the geriatric conditions and severity of those conditions closer to those who are age 75 or 80. From my discovery interviews with both healthcare providers and patients, it was evident that there was an unmet need. Patients wanted help with their hearing loss. They wanted that treated and help navigating the system. And providers wanted to know who to refer to, how, where was there a hearing aid benefit for those individuals, and expressed frustration that patients are just getting lost in the system. So one participant said, "My hearing loss affects me all day, every day. I don't feel safe in my surroundings and feel cut off from everyone. It's extremely frustrating." And a provider said, "We need a more efficient system. Providers don't understand the referral process and patients end up getting lost and sent to the general." So the proposed solution was to pilot a program through a partnership with Project Homeless Connect to provide both direct patient care and provider education and training. Project Homeless Connect was started in San Francisco, and their mission is to connect San Franciscans experiencing homelessness or at risk of experiencing homelessness with the care they need to move forward. So they provide a number of different medical and social services that are typically difficult to access for that population. Their newest program being the partnership with my organization, the Hearing and Speech Center. We are a safety net organization, and we believe that the right to communicate fully is a basic fundamental need. So our organizations aligned well to work together. So our year-one goals, we wanted to complete hearing screenings, we wanted to dispense hearing aids and accessories to 100 patients, and we wanted to be able to conduct educational training for up to 250 providers, with the ultimate goal being able to use that impact-based results and outcomes of the program model to potentially replicate and scale that statewide and nationally. So there are Project Homeless Connect organizations in every major city in California and throughout the US. So the potential to expand the program is super exciting in terms of both impact for the patients, but also potential overall reduction in those healthcare costs for the population. We began initial planning in September 2018. We signed an MOU with Project Homeless Connect, and we actually started implementing our program in January 2019. These results are represented through March 2020 when we had to put everything on hold due to COVID. But we were able to train 225 healthcare providers, fit 65 patients with hearing aids, including the gentleman that I mentioned at the beginning of my presentation. And we completed 200 hearing screenings. And an extra kind of, it wasn't part of the program, but a wonderful development was that we were able to connect 8 patients, 8 of those patients to our behavioral health team at clinic, and 6 of those patients were connected to our employment specialist. So the initial feedback from the program is positive. You know, a patient said, for the first time in a long time, I feel alive. Thank you so much. And a provider said, thank you for giving us the tools that meet the needs of our patients. So initial feedback was really positive. I was at the point where I was about to start assessing those impact-based outcomes. And then obviously COVID hit. And everything was put on pause. But we're able to kind of pause and pivot pretty quickly. We were able to still provide support for our community clinic partners and patients. So we transitioned all our clinical services to telehealth. We sourced and started supplying masks with clear panels to facilitate lip and speech reading, assistive listening devices, and hearing aid care kits to both our community partners and their patients. And we were fortunately able to continue the provider education and training component of the program remotely, which was I think there's always a silver lining, or I'm always trying to find a silver lining. And I think that the importance of communication and connection has been highlighted more so than ever during this pandemic. It has brought to light the fact that there is a lot of inadequate accessibility and accommodations for those with hearing loss in kind of this new virtual world, both for work, for telehealth appointments, for distance learning for teachers and students. And highlighting the negative effects of social isolation, which we know is a very common issue amongst those with hearing loss. So just a couple things on a leadership journey during this crisis. I mean, this is basically my everyday Zoom meeting. It's blurry, and that's just kind of how it goes. And I usually have 2 kiddos in my lap. But it kind of, it makes me smile because I actually started this program when I was pregnant in my 2nd. So to see this kind of come full circle and be able to present to all of you is such a privilege. And a couple of things that I learned this morning more in Patrick's session, but I was really worried that my type had changed. But after this morning session, that's just kind of how I react under stress. And I'm joking with Todd at one of our first meetings that one of my goals of the program was to be able to shut my office door without feeling bad about it. That door is not only shut, but got a do not disturb sign on it a lot of the time, and that's okay. It still makes me a well-rounded leader, and I'm doing the best I can. So next steps, we are going to resume all program services again starting next month. I'll meet with our stakeholders and update, revise that MOU as needed. We will follow up with patients to assess that impact-based outcome area. The qualitative feedback was positive, but we definitely need more quantitative data in order to secure more funding. And then I'll begin contacting other Project Homeless Connect organizations in California and start that discovery process all over again that Dave's such a fan of. With the ultimate goal of creating a sustainable model of care that can be replicated and scaled on a much larger level. Thank you. And I forgot to do an acknowledgement slide, but thank you to Tacoma Hearing and Speech Center, CHCF and their entire amazing team, Cohort 18, and the best pod ever. Thank you.
Thank you so much, Tracy. I'm going to give you a round of applause where I'm sure everyone else is clapping, but you can't hear them.
Yeah.
So I'm going to invite people to ask questions now. I didn't see any questions in the chat. Is there someone who would like to unmute and ask a question?
This is Sunita. I'll ask you one. Tracy, first of all, congratulations. Great project and great pivoting. No small feat. My question for you, and you allude to this in your last slide, is when you think about spreading this or scaling the work that you have done, what do you think is essential? What's it going to take for an organization to pick this up?
Yeah, I mean, the reason I partnered with Project Homeless Connect versus initially versus kind of reaching out to our community partners and going that route was that they have a very strong connection with those clients already. That trust has been established, and so it in some ways was an easier way to kind of get just even access to the population to even present what we wanted to do. So I think it's that collaboration piece. It's being able to, you know, have that one person. I have one particular person from Project Homeless Connect in San Francisco who is just a champion of this program. And I think if you find that one person, you can kind of build from that. And, you know, lots of emails and phone calls and begging and whatever you need to do to get things going.
Any other questions? All right, well, let's give another round of applause for Tracy. Thanks so much, Tracy.
Thank you, Tracy.
Go ahead, Dave.
Yep, I'm gonna go ahead. Thank you, Renee. Great project, and it was great to hear the leadership journey of that chip also, just to watch you and that story, that amazing story at the beginning of the homeless person that you met that caused you to go down this path is tremendous. We will have a 10-minute break after our next presenter, who is Winnie Teuteberg. She's the clinical associate professor at Stanford University. So Winnie, you're on.
Thank you, Dave. I will share my slides. Hopefully we're good.
You're good.
Great. So I'm so thrilled to have the opportunity to talk about my project, and just so grateful for the fellowship. So thank you, and I will get going. So these are pictures of people who I would imagine, or at least I can certainly imagine, might very well be my patients. And I'd like to ask all of you, how well do we really know our patients? And unfortunately, I often think the answer is that we mostly know what's in the electronic health record. That's certainly what I see my colleagues do, is get a new consult, see a new patient in clinic, and everyone dives into Epic or whichever EHR you have and starts digging up all this data. That's what I do when someone calls me with a consult. And I would say, you know, as a palliative care physician, that there's so much more to our patients than we can actually find in the electronic health record. One of the reasons I went into palliative care is because I figured this out early on in my career, and that was what brought me to medicine. This richness of human life and human experience that is really missing, I think, certainly from our electronic health record, what's important to patients, but also from the interactions that we sometimes have with our patients in this busy world. And so for years in my practice in palliative care, I struggled with how do we bring these pictures in this slide, all these non-medical things that are of vital importance to our patients, how do we bring those to the forefront of the clinical encounters that we have with our patients, particularly patients who have serious illness, who are approaching the end of life? So I struggled with this for a long time. And actually something came along that really excited me. So this is a picture of the Serious Illness Conversation Guide. It was developed at Ariadne Labs in Boston by two incredible people. One is Atul Gawande, who's a health improvement specialist and has become somewhat famous over the years. And then the woman in the circle is actually named Susan Block. She was one of my palliative care attendings when I was a fellow, and just an incredible human being and clinician. And she got together with Atul Gawande probably 10 years ago and said, how can we build some sort of structured approach that makes it easy for clinicians to talk to patients with serious illness, find out what they understand about their illness, share prognosis with them in language that's well received by patients, that doesn't feel abrupt or hurtful, and then get to all those things that are most important for patients, what they hope for, what they worry about. And I learned about this and I thought, oh my gosh, this is the most amazing thing. This is what we need. And then as luck would have it, I landed at Stanford 3 years ago after a move across the country. And our Department of Medicine was about to embark on a collaborative with Ariadne Labs and 7 other health systems across the country to roll out this program at Stanford. And they said, hey, you know, Winnie, you're new. You've done some similar work in the past. Why don't you lead this program? So here I was with this amazing opportunity on my lap. Seems like a slam dunk, right? I've got actually funding from my department, this beautiful tool, all this support. And so I really got ready to go. I got my team together. We hired a project manager. We started our implementation, and our leadership and our sponsors wanted us to start in our cancer center and really do what Ariadne Labs usually advises you to do, which is a physician-led implementation. And that really involves training clinicians on how to use that guide and then developing workflows to support the conversations to happen. So I got going and very quickly found myself in this very dark and cloudy space, despite actually finally living in sunny California, and was hearing things from the physicians like, this isn't my job. We already have too many metrics to meet. I don't have time for this. My schedule is overbooked as it is. My patients don't want this information. And it was really hard. I sat there and thought, I don't know if I'm going to be able to do this. Is this really going to work? And then something really amazing happened. And so I'm going to tell my story, which is, again, I think Tracy said that her chip kind of came to her. My chip came to me too. So I was on service in the hospital doing palliative care consults, taking care of a very sick woman with metastatic cancer and malignant bowel obstruction. And I was working very hard with the other physicians involved, trying to figure out how can we resolve this bowel obstruction so that she can get more chemo, because her outpatient oncologist wants her to get some food in her and go home and have more chemo. And so we were all thinking, oh, looking at x-rays, can we give her Reglan, all these things. And then this happened. So this is May Carr, who's just an incredible, inspiring human being. She's a dietitian on the inpatient oncology service and a real force of nature as a person. And she came up to me, she never met me before, and she said, hey, you know, Dr. Teuteberg, I think we need to have a family meeting. We need to talk to this patient about goals of care. And it was one of those things where I still remember standing there and looking at her, and all of a sudden she had like grabbed me by the back of my lab coat and sort of pulled me out of the trees, right? I was in there looking at all this little detail and I completely missed the big picture, which she said, you know, I've been taking care of this patient for 2 weeks in the hospital. She hasn't had any nutrition at all. And you people are talking about chemo. She's like, I think we need to talk to her. And so we had a family meeting. We shared prognosis with the patient, and the patient said, you know, if these are my chances and this is my prognosis, I really want to be home with my family. And she went home with hospice the next day. And so that really just kind of rocked my world, and happened to happen right around the time we had just finished our seminar, our first one. I was thinking about what is my how might we going to be, and she really gave it to me. So my how might we for my chip was, how might we leverage all members of the multidisciplinary team to support earlier, high-quality advanced care planning conversations for patients with serious illness? She helped me realize that all sorts of people are actually in there talking to patients, probably spending more time with them than physicians ever do, and know a lot about what's important to them. And yet we still are wanting the physicians to have these conversations, and the physicians are writing the medical plans. So I got started on my journey. I really got my act together, got working on my interviews. I ended up completing 49 interviews. And what I found was that often physicians execute treatment plans without sharing prognosis and discussing patient wishes. And that leads to delivering care that is often not concordant with the goals and values of the patient. And what was interesting, and which I didn't expect, is that this actually leads to moral distress for team members who care for these patients. So I interviewed all sorts of multidisciplinary team members in the hospital, and many providers told me this. And the other thing that was interesting when I talked to hospital leadership is this was a well-recognized problem, and that's why they'd funded my program in the first place. So I was ready. I had my project goals. I developed workflows to promote teams to share the work of having the conversations. We were going to train all members of the team, not just the doctors, but the dietitians and the speech therapists, everybody, have that contribute to the culture change with the goal of increasing conversations for patients with serious illness and thereby improving the quality of their care and hopefully alleviating their suffering and reducing burnout amongst those team members. I was so proud of myself. I got the leaders engaged. I got the stakeholders on board. I had my team. There was actually a similar project. Someone had gotten started on an advanced care planning project in the hospital and hospital medicine using AI, and my program was going to dovetail well with his. He was using my tool. We even got accepted to the Stanford CEL program, which is a leadership training program that provides a lot of extra support. And as luck would have it, I was going to start on May 11th, and I was going to graduate from that probably the week before this seminar. So I was going to be ready to go. And then this happened. So I was living in that COVID, oh my gosh, everything's completely derailed. But everyone kept saying, like, look for a silver lining, look for a silver lining. And in the end, I actually had one. And what it was is that we were able to pivot all of our trainings to virtual training. So one thing that had been a real barrier for us moving forward is that our trainings took almost 4 hours and they were in person. But because of COVID, we switched to a completely virtual training. And this is a screenshot of our wonderful trainer, Marina Martin, in the upper left-hand corner, one of our learners, and then our patient actor with COVID hair. He said I could only use his picture if I apologized for his haircut. So this is what we did, and it was down to an hour and a half, which was really wonderful, and actually made the trainings and moving forward with implementation much more scalable. And that allowed us to do this. So we continued with our work really with the support of our team. And I wanted to just show you how it became shared work. So these are conversations that were had with patients just by the attending physicians who we initially started with. And then we adding medical trainees, advanced practice providers, dietitians, spiritual care providers, social workers, occupational therapists, care coaches. And then you get to the end and you see that our conversations really went up, and it wasn't any one group that had them. It were all these colored bars at the bottom that came together to make this nice, robust blue bar at the top. So it really was teamwork. And the cool thing that I realized is that we actually got better and did better after COVID. I think probably from just getting some momentum and being scalable, our numbers went up after the COVID pandemic started. So what did I learn? I learned a lot, as many of us have. One is that you should never give up and keep trying. And I really credit my project manager and partner in this, who just kept sort of persevering when I wanted to throw in the towel. Leeway. So, you know, I worked with the hospital medicine folks who wanted to pair this with an AI model. I worked with the cancer center who wanted to do this paired with care coaches. I kind of let people really do it their way. And then that relationships are incredibly important. I had only been at Stanford for 6 months when I embarked on this project, and it really wasn't until I'd been there for a while and got to know people that they trusted me enough to move forward with the work. So I have lots of thank yous, and I'm not going to hit everybody in this, but these are my sponsors. My boss is at the very top, also some folks from Department of Medicine and from Ariadne Labs. These are all of our trainers who were doing in-person training, and now I'll do these amazing Zoom virtual trainings with role play and actors. This is my core team, and this is Britha in the center as our project manager, who really was the person who kind of moved me along. Also, Song Chang is the person I want to thank him, who really encouraged me to do this fellowship, even though I just landed in California, and it was an incredible experience. And then my amazing cohort, I don't know where I would be without you guys. You've all been a huge support to me. So thank you.
Thank you so much, Winnie. Round of applause. So I haven't seen any questions in the chat, but we'll invite people to unmute and ask a question if they have one.
Hi, this is Vanessa. Can you hear me?
Yes.
Winnie, forgive me if you said this and I didn't hear it, because you know I'm in Tahoe and the internet is quite janky. But I wonder that first of all, that's an incredible project. You all are making me feel like I really failed in this whole process, but it's beautiful to see what can be done. And my question for you is, how did the other team members feel about the medical part of the prognosis, and how were the docs about kind of letting go of that turf, so to speak?
Yeah, that's a great question. So actually, this is very much shared work, and I didn't have for 10 minutes to go through it, but we actually built the documentation form and the electronic health record. That's a living, breathing document. And so we often split up pieces of the conversation. So the guide talks through first assessing the patient's illness understanding, and then sharing prognosis. And then the bottom part are all the questions about exploring goals and values. And what we learned is that often the doctors are like, I don't have time to talk about all this touchy-feely stuff. They need to know it to make a plan, but they don't necessarily have time or want to do all that, where the other extended team members, you know, the dietitians and the physical therapists and the social workers are already in there encountering that information all the time. So we share the work. So often it's a hand back and forth. So the physician might give the prognosis and then say, and we did some training videos where I model this, when you say, thank you so much after you talk with the patient, and, you know, attend to their emotion, which is a big part of these conversations, to say, you know, another member of our team is going to spend some more time with you later today and learn more what's important to you. And then we're going to come back together and make a plan. So it was really interesting. Those team members often didn't want to take the prognosis. And so we said, okay, and that's where the leeway came in. People said, because the Ariadne Labs training is you just go through and one person goes through all this. And I quickly found that that wasn't going to work for all sorts of reasons. And so we had different folks pick it up. It was still a lot of work to be done with the teamwork aspect of it, but I think we're making progress.
Thank you.
This is Andy. Are we
Hi,
available
Andy.
for questions?
Yeah, go
Okay.
ahead. And then David Kampa, if you would like to ask your question next.
Fantastic. I really love how you develop insight through a lot of the interviews and how you formulated your plan and all your pivots. Congratulations. So my question is more about your model and scale. You had mentioned that, you know, you gathered insight and it was really already accepted by the hospital leadership. And through the implementation, you really augmented the staff members that really were having these conversations. What advice would you give for another hospital that don't have your program, that's trying to scale your program? How would you build stakeholders to really sell this particular approach?
Yeah, I think a big thing is to say that the patients need this information. There's actually some recent data came out of Penn, which I didn't show, who've implemented this program, that they have better cancer-related end-of-life outcomes when they have these conversations with their patients. So if you're looking for money, they actually have increased hospice utilization, those sorts of things, depending on who you're talking to. I think what I've found is that the physicians have a hard time with the time piece. And so if you tell them, well, we can share it, then they take it a little bit better. And then the other clinicians, they're actually happy. They just don't realize that all this data they're gathering from their patients is important and should be in the chart. So we even had a situation once where a nurse had this amazing conversation with the patient, but she's like, why would I put that in the chart? It's like, that's the most important thing. The patient told you that they don't want to die in the hospital, but you didn't put that in the chart. And so a lot of it is empowering them. And we have like all the non-physician people on the team are banging down our door to get trained. And so I think that's the biggest thing, is there's a lot of appetite for this. The funding is a little trickier, and we were super lucky. We're funded through our quality funds in the Department of Medicine. But I know the other thing is that a lot of the CMS pay for performance measures are now including advanced care planning, and this type of conversation actually checks that box to meet the advanced care planning measure for pay for performance. So that's another carrot potentially. And the other thing I think is that they're hard conversations. We're not just training people how to have the conversation, we're training them how to attend to the emotion that they dig up when they have these conversations.
David Kampa, are you there? Would you like to ask your question? And then Betsy will be the next and the last question.
Yeah, thank you, Renee. Hi, it's David Kampa, primary care physician, LA County Department of Health Services. Is there an outpatient version of this program? It seems like your program seems to be geared more toward the inpatient team.
No, it's interesting. We actually started on the outpatient side in the ambulatory cancer center, and they're doing the work in ambulatory oncology with these lay navigator care coaches having the goals and values part of the conversation and handing it back. We are going to be implementing soon in primary care, and we're doing some in inpatient. I think I really chose to do the team-based My CHIP project was inpatient because that dietitian was inpatient. And also I think I felt like starting in the inpatient, because inpatient work is so much more visible to our health system, would help with the culture change. But the really cool thing about this guide is it's very plastic. You can use it inpatient, outpatient, you can share it. You can actually use it talking to surrogate decision makers and not to patients. It's actually mostly, when it was designed, is mostly for use in the ambulatory setting. And we have a website if people want to, for the Ariadne Labs has our own website for the program, but also Stanford has a website that has all our training videos and things, which I could share.
Great, thank you.
All right, Betsy, your question.
Thank you. Winnie's fabulous chip, and I really applaud you bringing the whole team. That's really exciting. Everyone has a role. My question is, in my background, lean process improvement, so I'm all about standard process, standard work. But this is a tough conversation, right? Especially considering, different race, ethnicity, culture, beliefs. Do you find that you have to tweak this standard conversation based on, different culture belief? And if so, how did you do that? How do you train your team to do that?
That's a great question. And we've recognized very early on, so at Stanford, probably half of our patients don't speak English as their first language, and they're, 18 or 20 different languages that they speak, and lots of cultural differences. We recognized that that was a problem. We actually have someone else in Vancouver had the guides translated into other languages. And what we're supposed to do, and what we've told people to do, and it's it's one thing to say, it's much harder to get that into the culture, is we've actually trained our interpreters too. So if you use the guide and you go through the guide specific language and the interpreter uses the translated guide, you can come across very well, and it works fairly well. Not perfectly. It doesn't work well at all if you just try to have someone translate from, like, me talking with a patient in English and an interpreter translating. Doesn't work. So one example is, one of the questions in the guide is, what gives you strength? And I did this with an interpreter, and the patient was like wondering, like looking at me really funny, as a Spanish speaking patient, and her daughter luckily spoke both languages. She said, "Mom, she's not talking about going to the gym. She's talking about what gives you strength." And so that's been a really hard thing to implement. We have all the translations on our website, and that's one thing that we still definitely, we have a lot of work to do, and that's one that we have to really find a workflow, which I haven't landed on yet, to really ensure that the interpreted guides get used. That's a great question.
All right, a last round of applause for Winnie. Thank you. All right, we're going to take a 5-minute break now, so we'll be back at 4:45 to resume presentations. Thank you. Dave, we're at 1:45, 4:45. Would you like to resume?
Hi, I think I'm going to resume.
Melissa, you're on deck. Okay.
Hi, everyone. It's wonderful to see so many people on. And so far, the presentations have been fantastic. I'm looking forward to the next 3. The next up is Blake Gregory, who's the Medical Director of Highland Wellness Primary Care Clinics, Alameda Health System.
Hi, great to see familiar faces. And can everybody see my screen, my slides? Okay.
Yes.
Great. So I'm Blake Gregory, Medical Director for the Highland Wellness Clinics at Alameda Health System. And I'm really excited to present to you guys today. It's great actually to see a lot of people who I wound up interviewing for my CHIP who are here. And so it's wonderful to be able to close the loop and talk about how things turned out with this project. It had been a hard year, lurching from budget shortage to staffing crisis to an impending Epic rollout had me and my practice manager hanging by a thread. Many days I would wake up wanting to quit, but I kept showing up. One Thursday afternoon, I sat down with my practice manager for our one-on-one. We were chatting about our weekend plans. I have something to tell you, she said, her face growing serious. I am quitting. I have no support in this role, and I don't know how to solve these problems. She was stepping down in 3 weeks. Our Epic rollout was in a month. I begged her to stay for 2 more months so she could navigate us through go live. When I think about staying longer, she said, I get physically ill. In 6 years at my organization, I have seen every single manager position in my unit turn over 3 times. What is it about our organization that drives managers away? And so partly from this experience, my CHIP was born. I've done almost 50 interviews in the last 2 years, and I've started with one simple question when I talk to people. And I start by asking, what does workplace culture mean to you? I have learned a tremendous amount, and it's amazing to hear the diversity of opinions on this topic. But I think what's also been stunning to me is that there's almost a universal thread that I hear when I ask people this question. And almost invariably, people comment on the role of the middle manager in setting the tone of the work environment. So once I heard that enough times, it became clear where I needed to focus my CHIP. And that if I had to understand workplace culture, I needed to talk to the middle managers and target an intervention to support them. So when I talked to middle managers, I heard a number of themes. I heard language around, I was thrown into this role because there was a need. I didn't have much training or preparation. I heard about overwhelm. I heard managers saying that they were expected to solve problems that were outside of their scope to be able to fix. And then the big aha moment for me came when one medical director commented, I wonder if there are avenues for us as middle managers to solve problems together. We need more ways to pool our collective wisdom. So that was a really, really powerful insight for me. And that's really where my true CHIP was born. And I was able to consolidate these learnings into 2 how might we statements. How might we foster more peer support among middle managers? And how might we instill positive workplace culture by setting managers up to succeed? And the solution that became my CHIP, we call managers in the middle. And this is actually a name that the managers themselves came up with through a creative voting process. Managers in the Middle is a monthly managers only meeting with the goal of focusing on peer support, skill building, professional development. We have developed content for these meetings through key partnerships that include ambulatory managers and supervisors, but also human resources. And then in the future, we hope to closely partner with my organization's project management office, our lean office, and ambulatory system leadership. And so we have, in partnership with Human Resources, have actually developed an 18-month curriculum that we are implementing as part of Managers in the Middle. We developed this curriculum in collaboration with the managers themselves based on gaps that they felt they had in their knowledge that they would like to develop further, and also with HR just from their experience supporting employees and managers. The 4 key content areas that we identified as we developed our curriculum include psychological safety, communication, project management, and change management. And here is what the curriculum looks like. You can see that we were able to adapt to both international and sort of national topics that were important and have sort of come to the forefront. So we dedicated 2 months this summer to creating a safe space for talking about racism. This past month, we had a meeting about creating a culture of respect. And I don't know if Patrick is on this call, but we have 3 months carved out to do MBTI with the managers, because that's been an essential part of my professional development through this fellowship. We also have topics about empathy, leader rounding, supporting staff. We have topics around diversity, equity, and inclusion. So 2 sessions about supporting a diverse workforce. And then also just sort of the logistics of leading, including meeting management, project management, and change management. And we have been collecting data since the inception of this program, and I'd like to share that with you now. At the beginning, I was very interested in measuring manager engagement. And so before this project kicked off, I surveyed all the managers, asking them a net promoter score question. How likely are you to recommend our organization as a place to work to a colleague? And so we collected the baseline data in November 2019 before this program was implemented. And I think you can see we didn't do great. The baseline score for managers was -24. And the net promoter score, just for your reference, the lowest score you can get is -100, and the highest you can get is +100. So anything in the negative is not great, but that was our baseline score. And then 3 months into the Managers in the Middle meeting, we resurveyed in February of this year, asking the same question. And our scores had improved from -24 up to +36. And we were able to a large extent sustain that change even 7 months into the program in June of 2020, when we asked the question again, and the response was 24 for our net promoter score. And then just this month, we did a Managers in the Middle program assessment. And so we asked managers, do these meetings help foster peer support? Because that was a stated goal at the beginning of all this. And then we also asked managers whether these meetings help build upon skills they need to lead their team. And so almost 90% of managers agreed or strongly agreed with the statement that these meetings help build peer support. And then 76% stated that the meetings help build upon skills they need. And then we asked, similarly, do these meetings help support professional growth? And then lastly, is Managers in the Middle even worth continuing at all? And so is this something that the managers want to even move forward with? And so 65% of managers agreed or strongly agreed that Managers in the Middle helps with professional growth. And overwhelmingly, managers agreed that Managers in the Middle is worth continuing in some iteration, and no managers disagreed with this statement. We also tracked meeting attendance over time. And so you can see here that in December and January, when this first kicked off, we were seeing between 15 and 20 participants in the meetings. And then that number has continued to rise as word has gotten out about this program. People have wanted to get involved and just learn and grow professionally. And that was despite the necessary pivot to all Zoom meetings starting in April, of course, because of the pandemic. Zoom has posed its own challenges to these meetings and making sure people are still truly connecting in a meaningful way. And that's something we, of course, want to work on. But just looking globally at the trend, we have over doubled the participation in these meetings compared to January. So the next steps for this project, Now that we have great program assessment data, we have amazing feedback from the managers about ways to improve the program and what they would like to see in future iterations. Some of the feedback they've given is that they'd like to change up the timing of the meetings and make sure that it's a time that works for all of them each month. They also would like to partner more closely on content development, and even some of them would like to take the lead in leading some of this content presentation, which is exciting. So we have to integrate some of that feedback as we move forward. Then I also need to look at succession planning and handoff, and how do I separate myself from this project so it's less Blake's project and more of a project that has been developed for managers by managers. And so that handoff needs to be thought through in a democratic way that works for the group. And then there are additional unanswered questions about this program. So how does it impact things like manager performance? Does it impact turnover rate for employees and managers? Are we actually able to retain good people because of this program? And then what is the impact on employee and patient satisfaction? So these are all unknowns and things that do need to be explored. I have learned so much from this project. And so I think the salient things that I have taken away is that managers are hungry to learn. They want to be successful and they want to be effective. They have great insight into their skill gaps and are really excited to learn and grow. I've also learned that it pays huge dividends to make even small investments in manager development. And specifically, as we saw by the very rapid increase in our net promoter scores, managers are more likely to promote our organization as a place to work when they have the support they need. I've also found that this could be implemented at low, or in our case, zero cost. So I spent $0 on this project. Of course, apart from the cost of the manager's time, which is not trivial, but we at least didn't have to invest in curriculum development in a monetary way. I also learned that a dedicated champion is needed to drive this forward. And that in that particular case, it was me. It helps to protect that person's time to truly invest in quality content development. And while I didn't have that, I think that would be a meaningful thing to protect in the future. So now that I've, made a headway with this project, I've had time to reflect back on that conversation with my practice manager last year when she had something to tell me. And I wonder if managers in the middle, had it been a thing back when she was here, if that would have made a difference and if she might have stuck around or if it would have helped her feel more fulfilled in her role. And I don't know the answer to that question. But I do know that my current practice manager tells me managers in the middle is the best part of my month. And so I hope that this program is something that will help keep her here for years to come. So thank you so much for your time and attention, and I welcome your questions.
Thanks so much, Blake. Round of applause. You can hear from me. We have some questions in the chat, so we'll start with Judith and then we'll go to Laura.
Oh yeah, hi. Thank you so much for this presentation. It's really necessary, very interesting. I'm just curious of a couple questions about the cohort. Like how many people, I saw a little bit on the graph, but how many people did you have in the cohort? How did you recruit? And were these managers from different disciplines?
Great question. So they were all ambulatory managers. So it didn't involve like inpatient or post-acute, but all ambulatory, so primary care and specialty. And it included practice managers, medical directors, nurse supervisors, patient service supervisors, and then a grab bag of other people that don't fall into those categories. And so recruitment, I was fortunate to get a commitment from ambulatory system leadership to promote this project. And so they basically carved out time from a pre-existing meeting. So they shaved off an hour from a meeting that already existed so that I could have that time. They also set the expectation that these are mandatory meetings. We didn't do any enforcement at all on that, but we said, at least for now, while we're figuring this out and investing this time for you guys, we do expect you to attend. But I think even having said that, as you can see with the graph, it was always mandatory, but we got increased participation pretty much every single month. So we started with about 15 or 20 folks, but then, more folks heard about it and asked, hey, can I join? And so we just said whoever wants to join is welcome, as long as you're not like a C-suite person, because we did want to kind of protect that core group of people who are really in the middle, because that's what the content is targeted toward.
Can I ask a follow-up question by any
Sure.
chance? So I just, in my experience working in a similar setting, I've found that sometimes it's hard in a mixed discipline environment to get equal participation, particularly from people who aren't physicians. And I'm just curious, like, what you observed in your process and how you managed it.
Yeah, I mean, that's a great question and really, really important. I'm trying to think if there was any content. I mean, I don't know that there's any content that we presented so far that's focused on the hierarchy, although I completely acknowledge that that exists. And I see Laura Miller here, because I interviewed her, and that was a huge focus of what we talked about during my interview. Having not actually surveyed this, there has been a lot of work done in my organization about, I think, bringing at least the medical director and practice manager on a parity with each other and having like a lot of role clarity. Just in my experience seeing that process happen, my feeling is that there's a lot more empowerment for non-physician leaders in that group. Having said that, I haven't explicitly studied it or surveyed it. So that's really, really important. I appreciate your bringing that up. That's something else we need to look at.
We're going to just take one more question, and I know there are additional questions in the chat, so we'll get those to you, Blake, and share your contact info. So we'll go to Laura next.
Blake, fantastic talk. And again, I'm remembering talking to you. I wanted to ask you specifically about the racial and ethnic makeup of the middle managers group and how that plays out as it relates to within the group and then above and below in the very striking hierarchies that we work in.
Yeah, great question. Also, our manager group is actually pretty diverse. And so, like, for example, in my unit, 2 out of the 5 are women of color. Another identifies as LGBTQ, and so I would say even in our microcosm of a unit, we have diverse voices, and that's been very intentional in the way that we recruit managers. We actually get 100% engagement of staff as they choose their own boss, and that has led to tremendous diversity and really has impacted how we select people. But I would say at other sites, just off the top of my head, yeah, I mean, I think we have pretty good representation of people of color across ambulatory middle management. In the C-suite also, we have like our CEO and our COO are both people of color, and a number of folks in the level below. So I actually feel pretty good about the diversity of our organization. It's not that there's no more work to be done. And certainly the events of like May, June, July, and onward have really brought that to the forefront. And we've been explicitly talking about race a lot more, applying for grants that will help us promote equity in our organization and for our patients. So it's a work in progress, but I think there's mindfulness and that we just need to keep on this path. And also be mindful of that hierarchy, as you and I discussed, between staff and management, staff and providers, because that exists. It's important.
All right. Thank you, Blake. Round of applause.
Great job, Blake. Thank you. And thank you everyone for hanging in there. We have 2 more presentations. Up next, we have Mimi Duhan, who's the director of the Family Medicine Residency Program at Scripps Chula Vista Family Residency Program.
Hello, I'm actually one of the assistant directors, not the director, but thank you, Melissa.
Oh, they didn't have assistant in there. We promoted you.
Okay, let me share my screen. Let's see. And because my colleagues were having, okay, good. I just want to be sure I could do that. Okay, thank you everyone for joining us here today. My CHIP is called the Safe Haven Clinic Initiative, and it is purely an invention of this fellowship. I don't believe it would exist if I wasn't a fellow in this fellowship. And part of that is that I was brought together with such an amazing group of co-fellows, and they influenced me. And as well, the design thinking process greatly influenced me. I want to call out one in particular fellow, which is Shannon Smith Bernardine. And I want to thank her for her collaboration and the tremendous contribution she made to the development of this model. So what is the Safe Haven Clinic Initiative, and what is the Safe Haven Clinic in particular? It's designed through design thinking to fill a gap that exists in the continuum of care for people that are chronically experiencing homelessness and or addiction. It's meant to be a very low threshold first step into the continuum of care, and it's actually a facility with under one roof having medical respite, a street medicine program, a sobering center, and a pharmacy, all under one roof, integrated, and up to a 10-day length of stay with 24/7 nursing. So in all of the interviews that I did, everybody that I interviewed said, we need this, and it seems impossible. So that's how I started out on my journey. I'm going to be telling you quite a lot about where I have, how I've developed this model, but I've realized through the leadership journey that I'm on with this fellowship that I need to talk about where I'm coming from for you to understand where I'm going and why I'm so passionate about the Safe Haven Clinic Initiative, and indeed why I think this is going to be a focus of my career for the remainder of my career, for the rest of my working life. So my story starts out in Hamburg, Germany, where my mother was born Jewish in 1934, and she escaped with her family to Latin America, to South America, to Uruguay in particular. And this is a picture of her passport in Hamburg. And the picture above is her when she was 16 years old and her family finally arrived in Hayward, California in the 1950s, which was their intention all along, but they took a long journey through Latin America. But because of this, I had immigrant parents, both Spanish speaking, both refugees, both with a tremendous love of Latin America and also of America and of the opportunities in this country. But the trauma that my mother experienced led me to be homeless as a child because she had demons that drove her to the streets. And this is a picture of me and my little brother in the 1960s in the area of Berkeley. And I remember feeling what is expressed on my face, which is that I hated being homeless. And then I thought, when I grow up and I'm an adult someday, I'm going to do something to make this better. And this was the day that my father came and rescued my brother and I from homelessness. So my story Haven Clinic Initiative is going to move around California. It's going to begin in Santa Barbara, move up to Mendocino County, and then that's the red spot, and then down to the San Diego border of Chula Vista, where I am now. And I continue to remain connected to these areas and hope that one day each of these counties will have a Safe Haven clinic. So my journey with street medicine began when I first was in medical school at Stanford, and I went to hear Dr. Jim Withers speak in Washington, D.C. at a conference about street medicine. I had never heard of street medicine before, but he described how he would put a backpack on his back, he's an internist, and go out and meet people who are experiencing homelessness where they were. And then he had an interdisciplinary team, and the team worked in a way that is demonstrated by this picture where there was a transfer of trust. And this is a street psychiatrist and is reaching out to this gentleman who Dr. Withers, who's on the left, developed a trusting relationship with. And street medicine has an interdisciplinary approach, a trust-building approach where we meet people where they are. And I, like many people, many students and others who heard Dr. Withers speak, and this was in the late 90s, I said, when I get out of my training, I'm gonna do this. It spoke to me so deeply that I wanted to be a street medicine practitioner. So I was a family medicine resident in Contra Costa County at the Regional Medical Center there, and graduated in early 2000s. And when I went out of my graduation straight to Santa Barbara, where it's my home, and started a street medicine program at the same time that I started my private practice. And in the beginning, my focus was on disaster medicine as well as street medicine, because I believed that homelessness is a chronic disaster and that the principles of disaster medicine hold when we're doing street medicine as well. So this is the nonprofit that I started, and this is how we started out. So this is my very first team, and in the front is John Baker. He was a Iraq combat vet, just back from 2 tours in Iraq. He's our peacekeeper. Myself and 2 social workers, Jason and Jennifer, who worked for the county, and Dr. Bobby Gaines, who is the medical director of the Veterans Clinic. This is how we began, and since then, Doctors Without Walls has become quite a big nonprofit organization, but when we started, street medicine was new to Santa Barbara. And the other part of the disaster work of street medicine had to do with going out to this annual event in Isla Vista Halloween, called Isla Vista Halloween, where every year there was this massive street party, and we actually developed a sobering center for the street that was a mobile unit that went and helped young people get sober and get safely home. So then flash forward to more of the present time. In 2016, I moved up to Mendocino County and was asked by the CEO of the hospital, Gwen Matthews, a brilliant nurse leader, to start a street medicine program for Adventist Health Ukiah Valley. And I did that with the help of a grant that I wrote for Partnership Health Plan, funded the launch of the street medicine program. And as with this street medicine program, I found a similar experience that I did in Santa Barbara, which is that people that are experiencing chronic homelessness, it's very, very difficult to get people to get better. I mean, when you're living on the street and you have, behavioral health, you have addiction, burdens, it's so difficult to get out of that cycle. But Gwen Matthews sponsored me to be in this fellowship. I'm so grateful to her. She retired in 2019. And right around the time that she retired, I was asked by the new CEO of the hospital to write a HRSA, Rural Communities Opioid Response Program grant, which I did write for this for the Safe Haven Clinic initiative, and was awarded $1 million for that grant. And that grant is with Adventist Health Ukiah Valley. But it was during this time that with many of my conversations with my fellows, my cohort, that I realized that I needed to develop a new model, that street medicine was not enough. And that was how I came into the fellowship, was just going to focus on street medicine and disaster medicine, but the influence of my co-fellows influenced me in a different direction. So then there was a pivot, because as I said, there was a new CEO of the hospital, and this is about my leadership journey. I took a pivot at this point. I left behind that $1 million grant, and I moved over for a new opportunity in August of 2019 to be the health officer for Mendocino County. And when I did that, I was able to engage a foundation who believed in the Safe Haven Clinic initiative, the Arlene and Michael Rosen Foundation, and they pledged $700,000 for the Safe Haven Clinic initiative, and as well to the community. So at this time, my leadership journey was very influenced by other health officers around the country in terms of crisis communications and how important it is to build bridges and build more than you burn, and to also constantly pivot, because I became a health officer during COVID. So I became the health officer in August, and then was the health officer when the pandemic hit. And I was in the position where the sheriff made a statement on Facebook about me that actually put me in a position where I went into hiding for a period of time. And this was another lesson about how important it is to build bridges, because I'm very happy that the sheriff and I have a good relationship at this time. But we have to be very brave as leaders, and I learned those lessons. So this is the nature of my CHIP. It's the Safe Haven Clinic initiative, which I'm bringing from Mendocino to Chula Vista. And there's a website coming soon. Here's an infographic that's been developed. And the current focus right now is that I've been able to commandeer a building in Mendocino County, which is a skilled nursing facility, as the health officer during the pandemic. And we're planning on putting the Safe Haven Clinic here, the very first one, with a focus on mothers and youth. And this is the 5th District Supervisor, Ted Williams. Without his support, this would not be possible. This is how we've been planning, and there's Thank you to Dave for being one of our consultants on the project. In the middle is the CEO of Mendocino County, Carmel Angelo, and up to the upper left is Jason Satterfield from AMRF and other supporters of our team for starting the Safe Haven in Mendocino County. And now I'm moving to Chula Vista as Assistant Director of the Residency Program, and I'm looking also to bring the Safe Haven Clinic to Chula Vista. And the way we're starting with this, with the Arlene and Michael Rosen Foundation, is with an annual event called Border Health Rocks, and actually creating a brick and mortar design thinking workshop. So thank you to all of you. This is a thanks to everyone listening to my pink pod and my new notorious pod down in Southern California, to all of my co-fellows. And I want to say that as we have these projects, we also have to let them go. And I'm letting my project go to a certain extent and seeing where it's going to take root. And these are what my leadership journey taught me, which I mentioned in my presentation. But I want to be sure to end on this last slide to say that one of the most important things that I've gotten out of this fellowship, and thank you to my co-fellows, my Leaders of Color co-fellows, for the training we've gotten for the anti-racism work. So as a white woman, I want to say that that's some of the most important work of my life, along with the Safe Haven Clinic, will be the anti-racism work that I've learned so much during this fellowship. Thank you.
Thank you so much, Mimi. Round of applause. Does anyone have a question? Like to unmute yourselves and ask aloud?
Mimi, I don't have a question, but I have a comment. Congratulations. And my comment to you is I think it takes a huge amount of humility to learn in the moment of a lot of change and then to step away and to let things go where they need to go. So I just want to commend you for demonstrating that.
Any other questions or comments?
I have one.
Yes, Al.
Mimi, did you notice any differences between your work in Northern California and Southern California as far as, different types of cases or different disease processes that you ran into?
Wow, Al, that's such a big, such a deep question for me right now. Yes, so in Santa Barbara, the people that we took care of with street medicine, the chronically unsheltered people tend to be white men. In Mendocino County, in the rural community, their entire families, multi-generational families, pregnant women, children, which I didn't see in Santa Barbara. So the disparities in the rural space are absolutely evident. Also more people of First Nations people experiencing homelessness. Now on the Chula Vista space, this is something I'm learning about now, but I can see already that this is going to be a very unique and different community, and I'm very grateful to be working on the border. And I'm just learning about that community, the Chula Vista community now, but it's a border community. So yes, absolutely, it's different in every place, which is why in Mendocino County, we're gonna focus on women, parenting and pregnant women, and youth. There's a lot of youth homelessness in Mendocino County.
Hey, Mimi, this is Andy. Great presentation. I just had a question regarding this type of work. How do you recruit your core team? Because this is not just standard work. It seems like you're such a transformational leader. How do you recruit members of your team to work with you and to stay with you as you go through these obstacles and build these transformative programs?
Thank you. Well, I've had 2 street medicine teams myself now, one in Santa Barbara and one in Chula Vista. And that was through volunteerism, actually. And I've found, and it's a multidisciplinary team. And I've found that to be, there's kind of a rhythm of it, of the team being recruited and then forming the team. And it's been just beautiful work. And I haven't started a street medicine team yet in Chula Vista yet, but that is part of the plan. But it helps very much if we have student learners. So when I created the residency, well, I was the founder of the residency program in Ukiah, because that was the other ask when Matthews was, could I start a street medicine program and a residency program? So my intention always was to have resident physicians integrated and other learners. And so in Chula, that's absolutely part of the plan. There's such fantastic residency program there in Chula Vista. So having learners is just a natural, but for example, with John Baker, for my first team in Santa Barbara, the Iraq combat vet who was just back from war, he was, having veterans back from, who've been deployed is, for example, a great asset to any team.
Thank you, Mimi. Another round of applause.
Great job, Mimi. And finally, our last speaker is Bernard Palmer, and he's the attending physician at Alameda Health System.
Yeah, thanks everyone for the opportunity to present. It's really my leadership journey, and thanks for hanging on till the end of the day. Let me share here. All right, so this is my journey about the UIM pipeline project, and for clarification, I'm going to use the terms underrepresented medicine, UIM, and URM interchangeably. So the presence of healthcare inequities is not up for debate. They're very real, they're very significant, they're very present, and they mirror the uneven playing field that we see every day in America. And I think these issues have come really to the front in the past few months. What might surprise you, however, is that these inequities are really exacerbated by not having a diverse workforce. And we see it all the time. So imagine that you and your partner are about to deliver a child, and your doctor says to you, well, your new baby is about 3 times more likely to die than the white kid next door because I'm gonna deliver you. And if you had a black doctor, it would be better. But there's no black doctor available. Not enough exist. So we need to make a difference in the workforce and make that workforce match our population and our patient population. So I'm going to show a couple of stats, and we're going to focus on the green pie area. This is the United States population, and the green bar is the black people in America, representing about 13%. When you look at medical school graduates, that drops to about 6%. You look at who is practicing in America as physicians, it's about 3% are black. And then I have a particular interest in surgical residents and the surgical workforce, being the program director of the surgical residency in Oakland. Oakland is a very diverse place, and our program was founded by a very prominent black surgeon, and we live in his legacy. And so you can see here, the percentage of URMs in medicine also does not match the population. And as you get higher up in power, the numbers diminish even more, 2.2% of tenured surgical faculty. So we've all heard about the leaky pipeline and the pipeline that we need to fix. And at pretty much every level, there's attrition of underrepresented minorities. And by the time you get to medical school, very few exist. And I don't know if that's part of the pipeline itself, and many people argue that there's no one in the pipeline, and that's where we need to fix it. Or is it some point along the way that we need to make a difference? So our empty pipeline is resulting in a workforce that doesn't have enough underrepresented in medicine. So my project was to figure out how might we help more underrepresented get into medical school. And creating a diverse healthcare force ultimately will result in healthcare equity. And that's the goal. So a big problem for me was trying to determine where on the pipeline am I going to try to intervene and who to target. And with my interviews, I ran into a gentleman who was volunteering at the hospital, who was a non-traditional student. He was in community college, Cal State Hayward, after community college for graduate school. And he had mentioned, as a graduate post-bac person, he was not allowed to use the resources that the undergrads were allowed to use. He could not see any of the counseling, and he had no idea where to go. So I decided this was a niche that I could that I can look at. And this is a group of people that I would target. And so my chip ultimately, I called it Clinical Key. It was trying to create a medical school application guidance system for non-traditional UIMs, those who have been out of school for a little while, those who didn't go to the standard universities, those who are in community college, those who are going into post-bac programs, finding a way that they could find these resources. And I looked at Cal State East Bay for the project, and what it was to develop a centralized resource, a web-based resource, compiling all of the things that they would need to apply. Guidelines, counseling, someone to review their applications, finding mentors, linking them with organizations that are doing this type of work and can get them scholarships. Our outcome measures were going to be website hits, participation in activities, how many people use the resources, and how successful their applications are. Did they actually make it to medical school? And then COVID happened, and the chip fell apart a little bit, but actually with the virtual platform and web-based things, I could still progress. But then George Floyd happened, and that, for me, really changed everything. I was trying to process what was happening. I was looking actually for how to word an email to my residents to let them know how I was feeling. And it took me 48 hours to get the message out. But before I got the message out, my own Black residents called me out. They called me out for my silence. They called me out for my inaction, and they called me out for not caring and not supporting them. And I was upset with them. I was really upset with them. How dare they say that to me, who's their biggest supporter? But they were right, and they were right for being angry, and they were right that I was not supportive of them. So this is Christine, one of our recent graduates who really struggled in the residency. She struggled academically. She struggled with some communication. She almost got held back a couple of times. And I asked her and some of the other residents, what's going on here? And all of the Black residents said that I was not supportive of them, and the program was not supportive of them, which hurt. But it made me look at what was really happening. So I looked back at what was happening, and the circles are all our underrepresented residents of last year. And with the exception of the two in yellow, all of these residents had a major issue in residency, whether it's we threatened to hold them back, whether they had a communication problem, they were not meeting the standard, all of them had a major problem. And I realized the problem was not the residents, the problem is our program. The problem is our institution, the problem is our program, the problem is me as the leader of that program. And that was a wake-up call. And that's when my chip changed. And my new chip is creating a Black Residents Association and UIM programs for our residency, which seems so obvious, but we didn't have one. Every other place I've gone, in undergraduate, in medical school, all the other places I've been have a Black Resident Association or a Black Student Union, and we didn't have one. And this is my new mission. So we're creating this, and the goals are to increase retention and increase recruitment of our residents with the goal of making every one of them be able to make it through our program. We also want to provide personal professional support, increase the mentorship, provide networking activities, and involvement into specialty groups such as Latino Students Association, Student National Medical Association, so that they can see what's happening and make connections. Our plan is as follows: regular check-in meetings, augmenting the mentor system, creating a specific residency curriculum to meet the educational needs, mandating that they're all in a society, and create a new alumni network. These are our measures. We will look at UIM recruitment, retention attrition rates, and test scores. We want them all to participate in outreach events, those who aren't already, and we'll get the alumni involved. And what we've done so far is create the group, and that started in the middle of June. We have our monthly, at the minimum, monthly meetings, and we have quarterly UIM meetings. They are already involved in program improvement, such as how we do the evaluations. They are represented at those meetings, and their input is included and valued. And they are participating in recruitment, and they're making recommendations as how we recruit the next year and the next generations of residents to be here. So our next steps are really, can we create this mentor matching program, advertising for the residency, making this alumni network robust, and that's one of the things. And I think securing the funding can easily happen from our alumni network, and many people already have agreed to sponsor underrepresented residents, sending them to conferences, etc. Data collection is what's happening. And so this is our new happy family. And just to share a couple of the lessons. First, with everything going on, it's easy to look outside, but we have to critically look at ourselves and our own organizations. And me, I despite being a UIM, and I am just as much part of the problem as other people are. Smaller projects can have a large impact. I was looking to go outside the organization and create this huge network, but really just fixing what we have in our institution is going to make a huge difference. The implicit bias is pervasive. And again, it doesn't matter who you are. It doesn't matter if you're Black. We all have these biases. We all have these racist actions. And then the mentorship is critical at all levels. And you hear this over and over again. I link 4 and 5 together because I think the type of of support matters. I was not being supportive in the way that they need. And that's the difference between trying to get them to do what I need and giving them a plan versus really mentoring them and taking them under my wing. And I think that makes a huge difference. And that's how we can create the next leaders. So I just would like to thank CHCF for investing in me and for investing in making real change for California. To all of the fellows, both current and graduated, I'm really honored to be among you and to even to be considered among you with all the great work that you're doing. And I'm very privileged to work beside all of you.
Thank you so much. Round of applause, Bernard. David Kampa has a question, and then if anybody else has a question, we can go to you next.
Hi, Bernard. That was great presentation, great work. It's such incredibly important work, and I was wondering how the ACGME supports it across the country so that people like you don't have to do this on your own, but that it's an important and required part of residency training.
I'm actually very surprised how they've stepped up, and I think Black Lives Matter obviously push things, but they are mandating now that people include diversity and show how that you're doing that in your recruitment processes. And then it's not just saying it, they've actually put together a whole bunch of resources that they provide to all residents. So you can go to their website and see a lot of what their resources are, everything from what organizations to connect with to how to conduct interviews in an unbiased way.
Excellent presentation, Bernard. Have you been doing anything with the MMA and linking with their residents and residency program support system?
I have not yet, and I'm just figuring out what the larger organizations are and what to be part of. And I'm hoping that that's part of what our residents do, is all of the different UIMs collectively work together and with the other residency programs at our hospital to reach the larger organizations.
Well, you and I will talk, but I know the president now. He's a former Navy doc. When I was on active duty, he's the president of the NMA. So we'll chat offline.
Definitely, thank you.
Bernard, this is Lucy Tarin, program director down at White Memorial in Boyle Heights. And we're known very well for recruiting people of color to work in underserved communities. I got called out too, and it took a lot of soul searching to kind of come up to that. But I'm curious, is your organization one that historically recruits more minorities than typical? like your hospital?
Yeah, we historically do, and a surprisingly large number. And what's even more sobering is in the last few years, our numbers have declined significantly. And so when the next couple graduating classes finish, we're going to go down in numbers. So that's due to a number of different factors, but it's how we chose the metrics of how to pick people. But despite me ranking them very high and deliberately ranking a large number of UIMs high, they're not coming here. And I think part of that is other places are recruiting now more underrepresented. And I actually think that's a huge issue, and that's something we're going to have to battle.
Because you mentioned how ACGME now is part of their thing, which, I mean, I don't have an issue with that. That's kind of what we do, but that's challenging. There's obviously, you did the pipeline, there's not very many people of color that end up finally going into medicine, and now you're trying to fight over them with everyone else for them. But anyways, great presentation. Keep up the good work.
Thank you. Thanks.
All right, thank you, Bernard. Last round of applause.
Well, thanks everyone. This has been absolutely wonderful. It's been so nice to see everyone, and congratulations to all of the cohort speakers as well as all of cohort 18. I'm so impressed with all that you all have done despite all of the crises that have occurred throughout this last year. So congratulations. I look forward to seeing all of you as great leaders in California and abroad. And we look forward to talking more tomorrow. Renee, Sunita, I don't know if you guys have anything you want to add.
Yeah, so we can talk more at 6 p.m. tonight. So we have a networking event where we're going to help blend cohort 18 with some alumni so that you can chat and get to know each other a little bit better in that format. So if you can join us for that at 6 o'clock, that would be great. And then we will continue again tomorrow as well. So thank you very much. Congratulations. And we will see you all soon. Thank you. And bring your own drink.
Renee?
Gina?
I realize I didn't put the notes for the next one in the run of show. Do you want that in there now, or can
No.
roll with the doc? Okay.
Yeah, no, I have the slide that I'm going to show.
Okay.
And then you're good with breakout rooms, right?
Mm-hmm.
Okay. That's it. Christina, are you going to like sign off for the night? Or are you going to spend 5 more hours with us?
I want to sign off.
That was awesome, though.
Oh.
Yeah.
I'm not going to take it personally.
No, don't take it personally. I just got to go feed my hangry self. So.
Totally.
I got to go eat something. Yeah, so I will be signing off. Renee, are you going to stay on for the next 20 minutes?
I'm going to put it on pause for me. Do you want to chat now offline?
Yeah.
Okay. So I'm going to go and I'll grab a drink and stuff before we come back to this.
Okay. Okay, I'm going to leave. So I'm able to leave. So Gina, you're the host, so you're all set.
And it's the same invite, right? Okay.
Bye, Christina. Same invite. Hi, Maria. How are you?
Nice to see you.
Good to see you. You're all wearing pink and fun.
I know. Since
What?
you're leaving, I gotta say goodnight because the other two are staying. You guys are staying, right?
Yeah, the other two are staying.
The other two
Yeah,
are
I'm going to sign off, but I'll see you tomorrow, though.
Okay, well, I'm sending you a